Good morning. Welcome. I am Dr. Arlene Blake McCain. I'm a licensed medical doctor and public health specialist here and out of the island of Jamaica, an island that is located just about 90 miles south of Cuba and one plane ride from the state of Florida. One American Airlines plane ride from the state of Florida. Jamaica is an island that's the third largest English speaking Caribbean island. And we're the home of the reggae icon Bob Marley. We're the home of still the fastest man in the world, Usain Bolt, hands down for that. We're also the home of much more. We are the home of the beautiful beaches, white sand beaches. We're also the home of people that like to party and the home of persons that are brilliant, highly educated professionals. And we have doctors, we have nurses, we have our engineers, we have highly skilled workers, we have accountants in our island, of course, highly skilled professionals on our island, and they're exported all the time. So today, the conversation we're going to have in the sculpting series is about sculpting the foot. And I welcome today our foot specialist, Dr. Patricia Nowell, out of the United States of America, the state of New York. That the US is just north of Jamaica, so we have very close associations with the United States. And it's for that reason I did the introduction about Jamaica and where we are, where we're located, and the education of our peoples. And just to mention a little bit about Dr. Nowell, she's going to talk about herself a bit before she begins. She's a foot specialist, a podiatrist, but of course, she's of Caribbean ancestry from a country that is located in the northern border of South America, and that country is Guyana. So, welcome. Let's welcome Dr. Patricia Nowell. Welcome, Dr. Nowell.
Thank you, Dr. Blake McCain.
Hi. How are you today? So, how are you doing today?
I'm good, thank you.
Okay, great. We wanted to have the conversation today about the foot, and we wanted to have it in a very comfortable space so persons feel very comfortable understanding what we're talking about. And we hope that at the end of the conversation and the series that we're going to have, that persons will feel more comfortable going for medical care, knowing that there's a solution to their problems and their issues. So, Doc, tell me a little bit about podiatry. Why podiatry, and what is the study of podiatry?
Okay. Well, thank you for having me, first of all. I love your forum. I love what you're doing with integrative medicine. I like that you're encouraging and empowering people to be proactive about their healthcare and advocate for themselves. Podiatry is the practice of medicine and surgery of the foot and ankle. We're specialists who we deal with the ankle and the foot, as I mentioned, whether it's a medical issue or if we need surgical intervention. We take a multidisciplinary approach to our treatment of the foot. In other words, we'll involve your medical doctor. Sometimes we need to involve vascular specialists, circulation doctors, neurologists, and we access all the modalities out there that your doctor would use, whether it's X-ray, MRI, CT scan. We order blood work. Anything that your medical doctor does, we do for the foot and ankle.
For the foot and ankle. Okay.
Yeah.
So I didn't mention, but Dr. Nowell has over 25 years of experience in podiatry, and that's what she brings to the table. She's also the author of a book for persons who are considering a career in medicine. You'll hear more about that later. But she comes with a wealth of experience and love for what she does. And the whole idea is to have this talk today so persons can get an idea of how they can prevent certain conditions and how certain conditions can be attended to. All right, so today, episode 1 in the series is about diabetes and the foot of the diabetic person. The term the diabetic foot is used a lot, but for most of us in the Caribbean, when we think of the diabetic foot, we think of the worst case scenario. Isn't that so, Dr. Nowell? The worst case
That's
scenario. Definitely,
that's
right?
true.
When
That
persons
is
are
true.
losing toes and losing what we call the metatarsal region, which is the area just above the toe, and then persons lose the area below the knee. We don't want that to happen. We need to have that conversation long before that happens. And that is why the topic is the foot of the diabetic person or the foot of someone with diabetes with our foot specialist today. So, Dr. Nowell, what are the common conditions that you see with persons who have this diabetic foot or have a condition such as diabetes? But before you answer that, let's give the definition of diabetes for those who do not know what it is. So, diabetes is a systemic condition. It is considered a condition of the endocrine system of the body. So, that's the endocrine system is a system that has to do with your hormones and hormonal functions. And what happens is a hormone called insulin is produced from the pancreas, which is an organ located in the top left corner of your abdomen. So that's the tummy area just below the rib and just behind the stomach. But that's a little bit too much anatomy right there for some persons. But that pancreas is extremely important in producing a lot of enzymes for your digestion, but it also produces the hormone called insulin. So, what is happening now a lot in society is because of the foods that persons are eating or the environment they're exposed to, they're developing the condition called type 2 diabetes. Of course, there's also type 1 diabetes, which develops in the generally before the age of 18. However, we're having children as well that are developing type 2 diabetes because of the environment in which we now live, the very industrialized, fast paced nation where persons are having foods that are high in preservatives, highly processed, very poor nutrition, then they become overweight. And from overweight, they then become obese, too fat, too large. And then that causes a change in how your cells of the body then metabolize your sugars. So, diabetes, sugar. Sugar is high in the blood. That's it. But the problem with diabetes is not just the sugar being high in the blood. There are other things that happen, and that's a whole physiology, biochemistry lesson, which we're not going to go on to there. But basically, in simple terms, it causes the body to pop down, but over time, it takes years for it to happen. And they're very subtle signs, very subtle, meaning little things that happen. And that's what we're going to be looking at now. The little things that start to change in your body that could herald early signs of this diabetes. And so we're looking at that. We're looking at how early you should go and get that checkup, how early you should get looked at. So diabetes really is a systemic disease, but it affects the foot as well. And so we're going to talk about that. So, Dr. Nowell, tell us.
Okay. Well, as you know, there are about 800 million people worldwide dealing with this disease that have diabetes. Here in the US alone, we have 38 million diabetics, and we have about, I think, 1.2 million being diagnosed every year. As you know, diabetes, as you mentioned, diabetes it can affect the heart, it can affect our nerve system, our circulation, it affects our kidneys, and so much more. And one of the early signs is of all of these things, actually, is certain things that we see on the foot. Sometimes, actually, one of the earliest signs of diabetes is tingling in the toes. But basically, when a person is diagnosed with diabetes and they've had it for a few years, there are some things that also develop in the foot. Diabetes can affect as we mentioned, the nerves. The high blood sugar, it damages the blood cells, which in turn then damages or causes the nerves in your body to be undernourished, particularly the peripheral nerves. That's the nerves, meaning at the ends of let's say the fingers or the hands or the foot and the toes. And so you get the numbness and the tingling. Sometimes that's one of the first presentations of diabetes. Person goes into the doctor and says, "Doc, I have a lot of tingling in my toes. What is this?" Sometimes that's one of the earliest presentations. So that progresses as the years go on with diabetes, especially if the blood sugar is not controlled. That can get worse. I'll just leave it there for now.
Leave it there for
Diabetes,
now. So
yes.
just one thing to interject, something you mentioned just now. This is key. Most persons, as you just said, present with the symptoms or the signs of a problem caused by diabetes when they have tingling in the toes, yes, or
Yes,
numbness in the feet.
absolutely.
They're unable to feel their feet, or I'll add, when something has stuck them in the foot like a nail and it's sitting there for hours and they did not know because they cannot feel it.
Oh boy.
No, the
Yes,
key thing with that is usually these persons would have had this diabetes for at least 5 to 10 years before those symptoms present. Long
definitely.
before.
Yes.
Right? So by the time they
Exactly.
present to you, they've had it for 5 to 10 years and they did not know.
That's
They did not
correct.
know. They did not
That's
know.
correct. Mm-hmm.
Right. So having your checkup with your family doctor is extremely important for screening. A lot of persons now have at home this blood sugar machine that they can use to check for diabetes, but they do not know what they're interpreting. So a lot of people go to the Google doctor, which sometimes leads them astray because they do not have that knowledge, that complete knowledge of the science to interpret what they're actually looking at. So it makes sense for individuals to go for your checkup with your trusted medical physician, medical doctor. The family doctor is a good place to start. Sounds very simple, but it's extremely important to prevent what we're going to talk about now, which is 5 to 10 years down the road, right? And get that blood sugar checked and interpreted and followed up on. Because there are other factors we have to look at, but we're not going to talk about that today. Let's just talk about the foot and what are the things that you sometimes see in your patients that have come in with this diabetic foot and what you've had to treat, etc.
Yeah. So one of the other things we see besides the nerve being affected, causing neuropathy, the tingling and the numbness, we also see poor circulation, specifically your arterial circulation. Your arteries bring blood to the ends of your hands, the ends of your feet. It brings blood to your limbs. So what happens with diabetes, as the diabetes progresses, it starts to affect the arteries and they become clogged, and the smaller blood vessels become clogged and they're not bringing enough circulation, not enough blood to your foot, to your toes. And so we start to see issues with that, a lot of pain, coldness, the skin becomes dry and brittle, the skin starts to break down, people get, commonly called sores. We call them diabetic foot ulcers. And everything works together. The nerves being damaged, the circulation being damaged, all of those combine to cause the sores that are so commonly associated with diabetes.
Right.
Also, you mentioned the endocrine system. The endocrine system also can cause like dryness. Actually, some people get the opposite. They get excessive sweating, which is a problem. Some people get excessive dryness, which is also a problem. Either extreme can cause a problem in the skin and cause the skin, ultimately causing the skin to break down. And because the circulation is not there to heal, and because the nerves are damaged, and you can't sense certain things or process certain sensation, all of this combines or explodes to just cause a diabetic foot ulcer, which can be catastrophic, which I'm sure you're going to talk about later.
Yes, we're going to talk about that shortly. So just for persons to understand a little bit about what she made it very, very simple just now, so persons can understand what is happening. But persons don't make the link between the sugar and how it damages the nerves. It takes time to happen. Many persons believe that, oh, you're diabetic, and they just think that removing sugar, the actual name of the product, sugar, from the diet, solves the problem. But it's not just the sugar, which is the name of the product that you pick up in the supermarket, that brown sugar or that white sugar, or that sugar that you will find in a packaged product that you buy, and it's called sugar. There is high fructose corn syrup that belongs in the class of sugars. There is the carbohydrates. Let's talk about that big word. Yam, banana, rice, wheat flour, all of these things. I just make it really simple. The pastas, the pizza base, all of that are sugars when your body digests it. And so the treatment of that diabetes will have to be tailored. Would have to be tailored, not just the medication that you get, but we have to look at the diet that you have. But that's for another day, not today. But I wanted persons to get that part, that the sugars that you have that come as simple sugars or complex sugars in the form of the carbohydrates. I'll repeat it. The banana, I'm not saying you should stop eating it. So that's not what I'm saying. The flour, the rice, the pasta. It's the amount that you have it in that we need to take a look at, and how we need to change how that plate looks. The body is in disequilibrium. So the body is supposed to be in equilibrium. And then when you get diabetes, you end up with an imbalance, disequilibrium. And that's the problem. And that's why we have to tailor that diet. So with the sugars, as Dr. Nowell mentioned, that sugar, when the concentration is very high in the blood, it basically has nowhere to go. And it beats on your kidneys. I use that term. It beats on your kidneys. And the kidneys have a structure for filtering the blood. So you pee. The kidneys allow you to pee. And that's how you excrete the toxins from your body. I use that term toxins so persons understand. Every time you're peeing, you're getting rid of toxins. It's a good thing to pee. But peeing too much is a problem with diabetes, because then if you have very high sugar, it beats on your kidneys. There are changes that occur in the kidneys that then cause the sugar to spill over into the urine. That's a bad sign. The same thing happens in the nerves. So that sugar is now in high quantity in your bloodstream. So in your arteries and your veins, that's your bloodstream, those pipes that carry blood to the tissue, we call that the artery, and the pipe that removes the blood from the tissue level. Let's use the term your toes, for example, since we're talking about toes. So the pipe that carries blood to the toes, below the ankle, and the pipes that take the blood from the toes up to the rest of the body become affected because the sugar is too high. It takes time. It damages the blood vessel wall, and then that sugar gets converted into another form called sorbitol, which is a type of sugar product. That sorbitol, for those who like to read the Google doctors a lot, you'll find that word. That sorbitol deposits in your nerves as well. And that is the reason your nerves then become non-functional. They stop functioning well. And so you cannot feel. And how does it begin? Ma'am, I feel like my foot's tingling a bit. Here in our country, man, me can't feel my foot, you know. You know what go on me. I feel like a tingling thing down there every day, but me just get up and go work same way. That's for us Jamaicans, and the Caribbean people would understand. Another says, I can't feel my foot. I keep beating it. And I make that sound on purpose because there are patients I've met who do exactly that. They keep beating the foot and they beat it and beat it and beat it until one day that also develops because they haven't sought medical care. So, Dr. Nowell, do you treat diabetic ulcers? And, how do they come in? How do they look? What does it start out as? What does it look like when they come into you for the first time? And what is the treatment like when you're managing these diabetic foot ulcers, for example? Or before that, let's talk about the pain first, because that numbness happens first, and then the ulcers happen after. So let's talk about the different phases and what you see and what you do at the different phases of this process.
Well, okay, to talk about the nerves and how they affect the diabetic foot, yes, the patient, may present with sometimes a little, like we said in the beginning, a little tingling of the toes or the entire foot. But a lot of patients also have pain mixed with this. So there can be the two. And then as that tingling progresses, it progresses to a complete numbness. And that's years down the line. And, I don't want anyone listening to think that this is all unavoidable. This is preventable to some extent with, this is your field, Dr. Blake McCain, with good blood sugar control. All these symptoms, all these things that we're going to talk about now are preventable. But okay, so the that tingling and the pain, it progresses to numbness, also mixed with pain. So it's a diabolical condition, this neuropathy. You can have
Yeah.
numbness and you can have pain at different parts in the foot. And so that's the difficulty there. As time goes on, and combined with poor circulation as time goes on, the patient can or people can start presenting with maybe a little sore spot under the bottom of the foot, maybe a little callus. And that callus, it looks simple, and it can be simple. It's caused by pressure in a certain part of the foot that is bearing more weight than the other parts. And
If
so
I may
the
interject here just a bit,
body,
you use the word callus. Some persons don't know what that is. So it's that try to use very simple terms, simpler terms, at least for the population here. It's that hardening of the skin on the foot bottom. So in my country, we say the foot bottom. In another part, we say the sole of the feet. Some people say the bottom of the foot. Some people say the part you walk on. Like if you step on a stone, that part. It's the part just beneath the toes, right about here, the metatarsal, we call it metatarsal region, but just about right there. Persons tend to develop this callus on either one of those toes. You have 5 of them. We hope you still all have all 5 still. And you develop this hardening of the skin. And you know what persons do? Let's talk about this. They go to the foot. What shall I call them? The pedicurist. And then they go and they shave it off and they rub and they rub and they rub and they rub, not recognizing that for some persons who actually do have diabetes, they have this callus that begins, as you're about to say, then it becomes an ulcer because the circulation is poor. So there's a risk of that rubbing in persons who have diabetes and then go and have that foot rub. So we should really have the podiatrist take a look at that kind of foot, correct? With that callus in a diabetic patient, because there's a risk of infection in persons who just go to their cosmetic option, because everybody likes to have their nails done and their feet done. It feels nice to have it
Yeah.
rubbed, but we need to have it rubbed in context. And infections can occur if after that rubbing, something happens and the skin is nicked, a little cut. That's what I mean by nicked. A little cut happens, and then organisms, that's bacteria or fungi, bugs, move from outside the body into that little cut. So oftentimes they come and they say, it just started off like a little thing and I don't know what happened. I
Yeah.
don't know what happened. And they're quite traumatized by it, not understanding the methodology. We call it the physiopathology of what has taken place. That's our medical term. But for simplicity, the process that took place to make that happen. So that's where the podiatrist comes in for treatment of these calluses that could happen, that could cause other issues in the diabetic foot. So I'm going to let you continue to tell me about how you treat these calluses in
So,
persons with diabetic feet, and what happens next if an ulcer, they come into you with an ulcer.
yeah. So, yeah, you described the process well. After time of that callus, what did you call it? After the time of that callus remaining there, and there's nothing wrong with having it shaved down. It does help to ease the pain. However, the callus forms because it's protecting the body. Actually, it's not a bad thing. It's forming to protect. It's nature's way, your body's way of protecting that area from the excessive pressure. There's something with the bone that made it drop down below the level of the others, and so now it has a lot of pressure. The callus forms to protect it. But like you said, the constant shaving, the constant pressure. Whereas a non-diabetic with a good circulation and good nerves can tolerate it, can feel it, can know when to naturally offload it, meaning take the pressure off of it. Someone with diabetes is not going to sense, hey, I need to rest up off of this. They're not gonna sense that there's too much pressure in that area. And they continue walking and walking on it. The skin is becoming thinner, as you mentioned. And eventually the skin just breaks down and opens up into what we call an ulcer. It's all the way through. It's through the first layer of the skin, it's through the second layer of the skin, the epidermis, the dermis, and it can get even deeper. Some patients don't feel this until there have been patients who don't feel these wounds or these sore areas or sore spots until it has reached the layer before the bone, maybe the fatty area. Some patients even bone, especially in a thinner area. So it's not just on the bone areas, the bony areas that ulcers can form. They can also form in between the toes, in between where, for example, maybe we don't dry our feet as well after we get out of a shower or a bath or whatever. And the skin it stays damp. And so that dampness, it causes the skin to break down. And whereas, again, a non-diabetic may heal from that very easily. They have the adequate circulation, they have the adequate immune system to let them heal right away before they even notice, hey, there's a little cut in between my toes. A diabetic whose circulation has progressed to, not that good, their nerve sensation, what they feel is not that great. They have a little bit of numbness. They're not going to feel that breakdown. It opens up, becomes infected, forms an ulceration. And actually, these areas are worse than the bony areas because what happens, it travels through the soft tissue of the body. It travels through and goes deeper, deeper, deeper in the body.
So I love how you said that. So a fasciitis then is what could develop in the foot. So it travels through the fascia of the foot. So you
Well,
know,
it travels through different layers, forming an
layers
infection in the foot, not
causing an
just the
infection,
fascia.
not just
Yeah.
the fascia itself. Okay. So for the listeners, it means that self-care is foot care. It means when you have a bath, when you leave that bathroom, most persons just dry the upper body and through the door
Yes.
because they got to get to work. If you know
You
you're a
got it.
diabetic, you have to sit, find a place to sit down, and you pay attention to the toes. Dry the feet properly, dry in between the toes properly. Sounds so simple. Dry
Yes.
in between the toes properly. Then you take your hand and you open up the toes and you look at the front, you look at the back, you look to see if the area is damp. You need to get it as dry as possible. The skin changes. I call it, it's called maceration. So the skin becomes
Yes.
macerated. Like you're taking a piece of meat and you're pounding it before you cook it. You might not have a pressure cooker at home. For those who don't have a pressure cooker, that's what it starts to look like. Like you take a piece of meat and you pound it before you cook it. For persons from different parts of the world, depending on where you're from, you know exactly what I'm talking about. And that's how in between the toes begin to look. I do have pictures, but we'll share them at another time of what these feet can look. And these are real feet of real people I have seen. Diabetic feet or feet of the diabetic. So what happens between the toes? Let's describe the skin a little bit, Dr. Nowell. So I'll mention a few things. The skin becomes a little darkened. In some cases, it's a little red. In some cases, then it moves or it kind of lifts off a little bit like a plane,
Right.
and there's a little bubble underneath it. It's like, wait, what's going on here? And then when you take the towel and you wipe it, it kind of pops. Something's happening there. An infection of
Yeah.
some sort. What is the cause of the infection? You have to see your family doctor or your podiatrist for this. This can happen to non-diabetic patients as well, but we're talking about the diabetic patient here today. For the non-diabetic patient, the most common cause is the person who sweats a lot in their feet and they probably run, they probably wear lots of sneakers, if socks not very absorbent, it starts to happen. You probably work at a company where you're always walking in water, although you have on your protective shoes, your the steel toe boots they call them. So you might be working at a factory, you might be working at a wharf. These things happen and you walk through water, or sometimes the water is coming from your body itself in the form of sweat. And
Yeah.
then that then causes the changes in between the toes. And that's the beginning in most cases of a infection, commonly a fungal infection. It starts to look ugly, you don't want anybody to see your toes, things like that. It happens to both men and women, and men tend to sit with it
Right.
until it gets bad, and because we say that it festers.
Yeah.
So I thought I would mention that. So the other thing I must mention is this: persons who may have this diabetes, or maybe they're over 40 and they're looking at the toe, and then they come to you, Dr. Nowell, when it has become an ulcer, for example. They say, but I look at my toes every day. Why am I not seeing this? Or why did I not see this before? Now I'll tell you what it is. Something was wrong with your eyes, because diabetes affects the eyes. It affects the
Yeah.
vision. And
I left that out.
when it affects your vision, you're not seeing so well. It kind of look darkish. It looks dark. When you're looking at something, it looks dark. But to you, it's normal because you think you're aging. And it looks normal to you. And so it helps to ask a younger person at home who has 20/20 vision or better vision, hey, take a look at my toes for me, please. But they need to look at it for you as often every day. They take a look at it. So when they see a change, maybe a grandchild or something, they say, grandma, grandpa, the toes look a little different today. What you seeing, my child? They say, boy, look a little dark, because children are learning the colors in school. You have to learn how to use the family to help you to get better. So that's the whole idea of us having this conversation. It's not just about one person, it's about the family as well,
Yeah.
and involving everybody in the family in a
Yeah.
very tiny way in a part of this treatment. And so the child who's learning colors, it look black today, or it's looking a little dark, or it's looking a little red. Oh, I'm using. So it's a teaching moment as well for the child in the home. So you don't put a lot of pressure on the adult that has to
Yeah.
dash out to work because you're now the older person at home. And you probably feel like, Lord, I don't want to bother them. That kind of thing. I've seen that a lot. And it's sad. They come when it's too late. And they have that ulcer that we're talking about that will have to debride, fix and scoop out and dig out and so on. But Dr. Nowell, tell me some more about, is there anything else you wanted to add about the diabetic foot today that the podiatrist really takes a look at, treats? Is there any cutting that you do? Is there any medication that you give? Or are there persons you refer them to? Have you ever had to refer them to the orthopedic surgeon, for example, for further care? What is it really? So they understand this whole podiatry, which is actually a study of medicine and foot science itself.
Okay. So when you come into the podiatrist as a diabetic, we will start out with a foot examination. I'm sorry, we'll start out by asking you about your journey. What brought you in? What is your history? How long you've been a diabetic? What your blood sugar is. These are some things you should know. What your blood sugar is in the morning or after a meal. What your hemoglobin A1C is, because that gives us an idea of how well controlled your diabetes is, and what we can expect to see in the foot. We take x-rays. We'll take an x-ray to at least have a baseline of what's going on with your joints. So that's the other part I didn't talk about. With diabetes, even without diabetes, people can get bunions and hammer toes. Those are the deformities that form like in the big toe of your foot. You get the bending of the big toe. You get the bending of the forgive my hand.
It looks just like that.
Yeah. So you get the hammering of the toes. That can happen in anyone. In diabetics, these can cause problems. Again, because of that lack of circulation, because of that damage to the nerves, and because of the poor immune system. These deformities can again become ulcerated. They can become infected, leading to, especially if the patient has poor circulation, can lead to gangrene and can lead to amputation. Please notice I said can. It does not have to happen. All of this is preventable. So that's what the X-ray will help to show us how bad the deformity is. Because on the outside, we can see, okay, you have a bunion, you have a hammer toe. X-ray can help us to see, what else is going on. If anything is breaking down on the inside, there's something called Charcot foot that diabetics go on to develop. This is many years later of uncontrolled diabetes. Yes, that has affected the nerves where the joints inside the foot start to break down. And we can see that on X-ray. What else would we do? We test your nerves. We test your circulation by checking your pulses. Make sure you have nice, strong pulses. Or if we see that the pulse is weak, maybe it's time, because you asked, maybe it's time to send you to a vascular surgeon. If we, see certain things that indicate, okay, your blood sugar is not being controlled, and maybe you haven't been to your doctor in a while, we'll refer you back to your family physician, your GP, your internist for care. We should be
as you
coordinating with our patients and their
nutrition. Yes. As you mentioned this.
Nutrition is very important. So we have to pay attention to all of these things. It's not just looking at the foot. It's looking at the whole body also.
The
But
whole
this is what
body.
we'll do when, yes, when you come into the podiatrist, that is what we do. We check the nerves, the circulation, we check the joints on the outside, and we do the x-ray to check on the inside. And that's like the first exam that you'll get. We'll check the skin. That's important. Do you have fungus of the nails? Are you getting infections around the side of the nails called paronychia? In between the toes, is anything going on? Is it macerated, like you said? Are there any infections brewing in there? We check the bottom of the foot, very important. We check everything. We do a full exam up to your
Yes.
hips, and we see what kind of alignment you have, the hips, the knees, ankles, and yeah, basically we do a
That's it.
full exam. And we
Okay.
always coordinate, and we send a report back to whoever is your primary care physician. So or your GP, family doctor, we always work closely with your family doctor.
Very important. Very
And I
important.
like that you mentioned how the family is involved, the patient's family. Uh, One of the things you mentioned about checking the feet, we advise patients to check their feet every day, an everyday thing. Check in between the toes, check under the feet. If you don't see that well, as you mentioned and you described so vividly, get someone else in the family. Get a little kid in there to look down in between the toes, look under the feet to check for you. If you can see, but maybe you can't see well under there, put a mirror on the floor and hover your feet above the mirror and see what's going on underneath.
That's
Look,
so
that's what,
useful. What
yes,
you
yes.
just said is so useful because there are many persons who are premenopausal who can't bend their feet. They can't bend at the knee. Women, you know yourselves, can't even bend
Right.
at the knee to say, oh, let me look at the sole of my foot. Or here we say, me look on my foot bottom today. You know, in Jamaica or dialect, that's how you can't see it. So you don't know what's happening there. And so
Yeah.
putting that mirror, that's a very good idea. Excellent idea because
Yes.
it prevents problems
Yeah.
as well.
So
Um,
you mentioned about different treatments. Um, well, so we have something we call one of the simplest things we can do. Uh, it's called routine foot care. Let's say you come in, you have a nail infection. We'll try to get those nails down to where it's not going to cause a problem. It's not going to cause an infection. It's not causing pain. So those nails can be trimmed down. That's, very easy for us to do. If you have calluses at the bottom of your foot, we'll do the same thing that you may get done at you mentioned the nail salons or whatever. We'll shave that callus down. However, if there's something deep in there that needs to come out, it's causing severe pain, we do like a minor procedure in the office where we'll cut that out. But what podiatrists will also do is offload your foot. We'll take that pressure off your foot, and we can do that in various ways. We can use simple padding to do that. We can prescribe orthotics for you. I know you're very familiar with orthotics, Dr. Blake McCain. We can prescribe orthotics. It's like it's an insole that goes inside of your
insert.
shoe. So some people need a harder one, some people need a soft one, some people need combinations, some people need things added to the orthotics. And that's where podiatry comes in. We know what, would be needed to be added to that orthotic to make our patients comfortable and to take that pressure off of their foot. The important thing is to take the pressure off of that compromised area.
Let's
So
ask a
that's some of the
question.
things that we do. Mhm.
A question just to elucidate a little bit more. Orthotics. So Dr. Nowell mentioned orthotics. So that's the insole. It's an insole, correct? Right. So it's an
Yes.
insole. But they're the ready-made ones that are sold in our pharmacies. And there are a lot of persons that's women, men, they have problems with their feet. Easy to buy. They go to the pharmacy and they pick up these insoles. Dr. Scholl's is a very popular brand here. I'm sure there are others. But Is it possible for you to describe these types of insoles that you know about that exist? That's the orthotics. That's the medical term, orthotics. So you have the ready-made ones and you have the ones that can be customized just for you. And persons would go to the orthotic specialist, right? So someone who specializes in orthotics, and they actually have you walk on a special device. They look at your foot and they send this for customization. It's made to fit your foot so it can go
Right.
into your shoe. Uh, just a little teaser here. A lot of people are flat footed and have pain because they're flat footed. They don't even know what flat footed means, but we'll talk about that another time. And would need this orthotic device, this insole. But for the diabetic foot, these insoles that you speak of, persons will ask, should they be cushioned? Should they be soft? How soft should they be? Because the diabetic cannot feel their feet because the feet feel numb. They have this tingling, which we call paresthesia, and it feels numb. So if the shoe is not soft on the inside, they can have injuries from a shoe that's not soft on the inside. For them, it's okay for everybody else, but for them, it's different
Right.
because you're not feeling. How do you help
Correct.
such patients who come in, or such persons that come in? What do you recommend? Where do you send them to? Do you send them to a pharmacy, or is it customized? What is it that you do for such persons if they should go to the podiatrist? As we come to the close of our conversation here, let's talk about what someone at home right now, today, can do for themselves to make the inside of that shoe that they wear more comfortable for themselves or safer for themselves, them having this diabetic foot. What can they do today before they see their podiatrist, or while they're en route to the podiatrist, or while they're en route to a family doctor or a general practitioner like myself? What can they do to help themselves?
Okay. Well, if I start from the top, the main thing is to always try to keep your blood sugar under control. That's the number one thing. Okay, I said it, so that's out the way. That's always the number one thing. What can they do to keep their feet comfortable? Wear a comfortable, it really depends. There's some people who have flat feet, as you said, and the foot is, it's flexible, it's it doesn't feel like it's supported. So those people can get themselves a nice little arch support, something with a nice soft covering on it, but with a good support underneath, because orthotics come in layers. So, depending on what type of foot type you have, and patients can sense this for themselves. I can't wear a rigid shoe. I need something really soft and flexible that I can bend. That's me personally. Everyone knows themselves. So yes, diabetics, their sensation is compromised. But so you said on the way to the podiatrist, wear something that's comfortable for you
And
before
so,
you're diagnosed. Wear something
right.
that's comfortable.
And
Wear a shoe
shoes,
that's not too tight. You have a
right,
little bit of room in your shoe.
right.
You check your shoe. If you're diabetic and you're not that well controlled, check and you have the numbness and the tingling. You may not be able to detect if a little something drops in that shoe, a little nail, a little piece of
Pebble.
something, a little piece of glass. Yes, a little pebble. Check your shoes, the inside of your shoes before you put them on. Okay, that's one thing you can do. That's an important thing to do. If you want to buy something to feel more comfortable, like I said, if you're flat-footed, you might want to buy something with a little arch in it, but a nice soft covering. And just be comfortable in that shoe. If you can't feel, if you're really having numbness, get someone to check the shoe for you. The shoe should have like a little 1/2 inch space in between the toes and the end of the shoe. Get someone to check it and make sure, hey, this shoe is big enough for you. It has enough room. And that's from toe to top, and also with the width also. You know, you should be able to wiggle around a bit in the shoe. So you have someone check that for you if you're severely numb and you can't feel anything.
Dr. Pat, thank you for that valuable
if you have
information.
sensation, you know, you can check it for yourself. You should be able to get a finger in that shoe and be able to move it around.
Thank you for that invaluable information that you've shared. Very important about that shoe that you've mentioned. Have someone check it for you and have some wiggle room. There are persons who wear their shoes, and when their toes are in the shoes, it looks like this. Like this, they always forget that they have 5 toes, eh? Is that little one that's left behind always ends up like this or underneath?
Dr. Arlene. It happens to the best of us.
It happens, but then for the diabetic, we have to pay attention. And that is why I mentioned it. It's a very serious thing. We do not want them to develop bruises to the toes because they're not feeling the feet. We do not want them to have that ulcer. And because of the problem with the circulation, the blood supply to the foot, because of the diabetes, poor oxygenation, so low oxygen going to that area in the toe, because it's the end of your arteries, the end of the road, like the end of the water supply. It's the same thing. End of the tributary. Right. And so they end up with these ulcers. It's unfortunate that when this happens, then they lose the toe. One toe goes and toe number 2, then and so on and so on. That is what we're trying to prevent: amputation and loss of the feet. So I really appreciate that which you've explained today to the audience, the way you've explained it, how comfortably you've done it, and in such very, very simple terms for everybody to understand. And I hope that they paid attention, to this, because it's extremely important in how persons treat their feet, particularly if they're diabetic. Now, I will add this as a closure and for persons to actually take home. And this is a real story. I once had a patient, she's still alive, and I'm thankful for that, diabetic, walking in her slippers in the yard at home, and she got stuck by a nail. The nail went, it wasn't even a slippers, it was a thick shoe, like a clog or a Crocs or the thick clog. So it was really thick because she described it to me, but the yard she was walking in had a concrete nail. And the concrete nail went up through that very thick shoe because it's made of some kind of rubbery kind of material. So it's not a hard base. It makes a difference. It went up, and it's like these nails just like to stick people in a particular zone. It's like, yes, we love the big toe. So it's between the big toe and the other toe. And it stuck her there. And unfortunately for her, because of the diabetes, she wasn't able to feel it. So she was walking around with the nail in her foot for hours, probably a whole day. And then she took the shoe off and she saw some blood. She said, "What's this? Why is there blood in my shoe?" And that's when she looked at the shoe and she said, "Holy Father, what is this? It's a nail." And then she says, "Okay, let's check my foot." And when she looked at the foot, she realized that it had stuck her. So that's a sad story. And this is a common story among diabetics. People work on the farms, people are outdoors, just at home. Sometimes it's a pebble and this happens. We want to prevent that. So wear shoes with a proper sole that will protect your feet and with space in it, and check that foot every single day. You have to do it. It's a must. and try to keep that blood sugar under control. And it's
Absolutely.
not just the sugar, it's everything else, the obesity, the type of food. That's a whole other story. But your general practitioner and your family doctor or your diabetologist, because we do have diabetologists in Jamaica as well, and we have wonderful family practitioners and general practitioners and internists who can help you to keep that sugar under control before you get to the surgeon, before you get to the podiatrist, and before you get to the surgeon. Because by the time we send you to the general surgeon, it's clip time, and it's
Oh
not
boy.
nice. We don't
Yeah.
want that, right? So
Right.
that is why I mentioned it. So the simple things that Dr. Nowell mentioned can save your foot, and not just that, your life. Because once that diabetic foot becomes infected, let me tell you, it moves faster than the Concorde, faster than
Yeah.
lightning. You go to sleep tonight and you wake up several hours later, and from your foot up to your knee is red and swollen, and you are sick, meaning you have what we call in medicine sepsis, and it's not good. You can lose your life. So let us pay attention to that foot. And I'd like to thank Dr. Nowell today for coming for first episode in Sculpting Your Foot series. And today we spoke of the foot of the diabetic person, and we also spoke about the diabetic foot, right? And one thing we'll always say is prevention is better than cure. And for those
Yeah.
who are biblically oriented, the body is made up of many parts. It's one whole body with many parts. The foot is a part of that body. And so you pay attention to the foot, but you have to pay attention to the body. At our next session, we'll talk about which verse in the Bible that is. Okay? There, right? It's there.
Yes.
Thanks again, Dr. Nowell, for joining us.
Thank you. Thank you so much for having me. I really appreciate it. I'd love to come back and talk about prevention and various treatments that are available. I feel like we didn't touch enough on that. We
Oh, we
talked
can
about
do
some of the
that.
horrors. So another time I'd love to come back and talk about prevention
We
and
should.
treatment,
We
latest
will. We
treatments.
will. And we'll have
And
some pictures
I
as
really
well.
appreciate, yes, I appreciate the work that you, Dr. Blake McCain, and Dr. Ben Israel do in terms of educating everyone about natural, or as you call it, integrative medicine, medical ways that you can manage all of these problems, these especially in diabetes, other problems, other medical problems that we suffer from. There are a lot of more integrative ways to treat these problems, using naturopathic medicine, using technology, using AI, using things that are less intrusive. And I'd love to hear more from you guys, and I'd love to come back and talk about some of those things also, as
Yes,
far as the
we
doctor
should
goes.
have a Sculpting the Foot series roundtable talk. If we get Dr.
Yeah.
Ben Israel on, then we'll definitely have, so we have myself and you as a podiatrist and Dr. Ben Israel again as a naturopath, because it's important that we look at the what I call the holistic way of treating the body. I've been practicing for almost 2 decades. Or I think I missed my count. It's probably more than 2 decades by now.
Don't
And
go
I
past the 2 decades.
Oh God. So, but I've just seen so much of persons who have lost their toes and feet to diabetes. I say diabetes because I speak Spanish. Yo hablo español, así que digo diabetes a veces. I'm sorry. I
Mhm.
apologize. It just comes out. But diabetes, and I had to amputate a few. It was not pleasant to do.
Mhm.
It was not pleasant. So we want persons to get things in
Prevention.
now. Yeah,
Prevention. Hmm.
prevention before we get
Yeah.
to that stage. Because
Hmm.
we know the immune system of the diabetic person is affected.
Yeah.
So when you get that stick, we have to treat you like a newborn baby. You gotta
Yeah.
come in and get treated
That's
like a
right.
newborn baby, because if we miss a day or two with you, listen to me, not good. And I didn't like seeing it in my population, and I think we can do better for ourselves, and that's the reason we
Yeah.
had the talk today. But thank you for joining us, and we'll have our next episode soon, and we'll inform them about it.
Thank you so much, Dr. Blake McCain.
All right, bye.
Bye-bye.
Okay.